Hello, everyone. Welcome to our Monday Facebook Live. I'm sitting here at Regenexx headquarters in Broomfield, Colorado, with Regenexx founder and chief medical officer, Dr. Chris Centeno. I'm excited. We've got a great episode today, and we're going to talk about Dr. Google results and what you can find online versus what are the real published results and who's giving us this information. So let's turn it over and get started. There's so many good things to talk about around this today.
Yeah, we'll mix in some stuff with spine as well because we had said that we were going to talk about spine. So, yeah, this last week I did a blog post on Dr. Google, and it actually happened just because I was out there and I was doing some searching and for something else, and I typed in knee replacement results. And next thing you know, Dr. Google told me that knee replacement was 90% successful. And that came off the University of Washington website. And I knew that Google had made some algorithm changes this last year to kind of prioritize health information from university websites. And it made some common sense because maybe that's more reliable information. But when I actually ran that through the ringer of looking at what's been published, the knee replacement results are nowhere near 90%. And it was absolutely, misleading information that was on this University of Washington website. So it was interesting. It was a good test of Dr. Google and Google's new algorithm changes. And regrettably, it showed that Google had failed pretty spectacularly in misleading patients. That this was a highly successful surgery and really exaggerating the success rate substantially. So it was an interesting experiment, to say the least.
And you would think that the university would validate or verify what they were putting out there as to be accurate. Wouldn't you think that to be the case?
Yeah, a lot of university web pages do have some scientific citations. This one did not have any medical research. It was just this guy's opinion. So it was almost like they hired a web developer to interview this guy who then wrote a page. They probably had a writer write the page and the guy signed off on it. But it was, pretty good misinformation. As an example, he had said that 90% of patients who have knee replacement report little or no pain after the procedure, when in fact about 40 to 45% of patients who have knee replacement are still in substantial pain despite the surgery. So a lot of stuff like that. So it was pretty interesting. And then we also wanted to talk about spine, the difference between a real spine procedure and a fake procedure. I continue to blog about this because we continue to see it out there. We continue to see clinics that are offering fake spine procedures. So this last week I blogged about Dr. Tammy in Seattle. It's another Washington thing. I was kind of on a Washington state gig there. And this was a medical provider who claimed that she had 2 board certifications. When you looked into it, there was no actual ABMS board certification in anything. These were really just coursework that she had done that claimed to be board certifications, but they're not. And then more importantly, diving into what was done with regard to spine, which is just simple ligament and trigger point injections into muscles, and how dramatically different that is from an actual spine procedure using orthobiologics, where you're using x-ray guidance, ultrasound guidance, injecting into the disc, injecting around nerves, into facet joints, etc. So what was done was way down there, and what could be done was way up here. But patients don't know the difference between that gap. They'll walk into a Dr. Tammy type clinic and believe they're actually getting a real spine procedure when in fact they're not. They're kind of getting a fake and bake version of what a spine procedure could be.
Yeah, that's too bad because both sides, right, coming from a university and coming from somebody who's promoting themselves can steer people, to get something that isn't going to work for them, something that's a waste of money, something that's potentially dangerous.
Yeah, and I think it's just the common theme there is truth in advertising, right?
Yeah.
Dr. Tammy wasn't really truthful that she was board certified in anything. In addition to that, she didn't really state, I can do a little bit of spine here and there. These are things I can inject. But there's a whole bunch more to spine that I'm offering, so you may want to go elsewhere to get that procedure done. And in the same way, University of Washington should have had scientific citations on that page. They shouldn't have made really a dumbbell statement like, this is a 90% effective procedure. God, the only thing that's 90% plus effective in medicine is antibiotics for strep throat. There's nothing else that's 90% plus effective in medicine. It doesn't exist. So that was just a silly comment to make, clearly someone's opinion, but that wasn't based in any reality.
Yeah, right. So back to the spine. So we treat a lot of different conditions, well you do, with spine injections, facets, epidurals, occasionally in the disc, ligaments. Can you talk a little bit about sort of each one of those and sort of what you're injecting and how you target those and what symptoms people might be having?
Yeah, so there's a lot that can be injected in the spine. Usually it requires x-ray guidance, but some of it can be done under ultrasound as well. So there's superficial things that you can inject. You can inject the ligaments or the muscles, and that's kind of a Dr. Tammy level injection. Then you get into deeper structures like facet joints, which are the little joints between the spinal levels that can get arthritis or get damaged and injured. Then you've actually got the epidural space, which is around the nerves. So to target those areas, you've got to go even deeper than the facet joint. And then you can go even deeper than that, where you've got to put a needle past nerves without hitting them. And then you get into the disc, and that can only really be done with x-ray guidance. So a lot can be done there, kind of going from the surface on down. The simple surface stuff can be done just in the clinic by someone who's just palpating, but everything deeper needs imaging guidance. And those procedures take residents and fellows months to years to learn how to do well. So it's not something you can go to a weekend course on and learn. There's entire fellowships that happen on how to do those procedures the right way.
Right, in the cervical spine, in the neck, even more precision and potential risk if you're not skilled at it, right?
Yeah, so in the cervical spine, obviously you can hit the spinal cord, so that's a bad day for everybody. Never done that, don't ever intend on doing it. But again, you've got to be very careful with these injections. If you're doing blind injections in the neck, you can inject too deep and really harm somebody. Same thing in the back as well. You've got to be careful with these procedures. So it's a matter of trying to find someone who can do, so if you're going to get a stem cell procedure or a platelet-based procedure, all of those types of controls are required. And we're a little bit early here, so our fan base usually knows that these are at 4:30. We decided to pull the trigger and go a little early today, so people may be expecting this at 4:30. We got started a little bit before 4:15.
So I want to recommend too, on the Regenexx.com website, in the spine section, we've got a great spine book that Dr. Centeno wrote that goes into a lot of these types of procedures, and with good pictures. We've got great videos there. There's a spine webinar, I think, that you go through. So there's a lot of resources that if you or a family or a friend are looking for solutions to spine pain, please go to the Regenexx.com page and look under the spine section. I can tell you personally for myself, I probably have a neck that could be fused, which I've taken care of plenty of people that didn't work. And when that doesn't work, it ruins lives and families.
Yeah, and I've got a neck that should have had fusion a long time ago. It's kind of a funny story. I had seen a family friend of ours who had a neck that could have needed surgery. Rather than doing it non-surgically, she decided she wanted the surgery. Didn't go so well. And around that same time, I had my first MRI of the neck, which looked worse than hers. And here I am 4 years later, haven't had a single surgery. We've been treating it using platelet-based procedures. I haven't had one of those in a year and a half or so. So it's amazing what can be done with injection-based procedures to avoid surgery. In fact, some of the work we're doing now with lumbar stenosis still freaks me out, because I would have told anyone 5 years ago that some of these patients that we're currently treating successfully without surgery using X-ray guided procedures and platelets would be impossible. There's no way that person would need to be surgically decompressed and opened up. So interesting times to see some of the results that we're getting, but again, using very precise, specific procedures that are difficult to master and have to be done under X-ray guidance to make them work.
What do you think's happening with the stenosis? And if you can explain a little bit more about what that is with what you're doing, that you're so surprised by what you're seeing.
Yeah, so lumbar stenosis is when the central canal or the hole in the vertebra where the spinal cord and nerves go through gets too small. And a lot of times it gets too small due to arthritis, but the biggest single cause is hypertrophy of a ligament that's in the back called ligament inflavum. So that's a ligament in the back part of the spinal canal that can get bigger, and in some patients it starts pushing on nerves. In particular, when you stand up, it kind of pushes into the spinal canal, and when you bend forward, it kind of flattens it out and it pulls it back. So those are patients that can sit all day, but if they go to stand, they can stand for maybe 5 or 10 minutes and they start getting back pain or stuff going down their legs. Or if you see them in the grocery store, they're the people kind of leaning forward on a walker or leaning forward on a shopping cart because that's how they have to walk to make it comfortable, because that's opening up and pulling that ligament back out of the canal. Now there's some devices that have been developed now. I mean, the traditional procedures, you go in, you just kind of open the whole thing up, take some bone out, and take the ligament out. Now that's a huge surgery, and the research has shown that 4 years after the surgery, the people who got it and didn't get it are about the same place. Then we've got, more recently, some devices have been created to kind of push the back part up or apart and to stretch out that ligament, but those destroy tissue putting them in. So what we've been doing is what I call a flavoplasty approach, and that is we're doing direct injection of the swollen ligament to try to get it to buckle less into the canal and tighten down and become smaller. And all we need is a millimeter or two, but what's been really fascinating is taking someone who can only stand for 5 minutes and getting them to be able to stand for 2 hours. When you can stand for 2 hours, that's functional.
Yeah. If
you can only stand for 5 minutes, you can't function. You can't even go to a party and talk to anyone because you got to sit down after 5 minutes. Or you can't even go to shopping at the mall because you can't be vertical for that long. So it's been a real interesting thing to see routinely now that we're taking people that would have had lumbar fusion and wide laminectomy and getting them to be able to stand longer.
What causes that ligament of hypertrophy? Is it a stabilizing ligament, keeping things from moving around?
Yeah, that's part of it. Realize that the body makes things bigger in the ligament tendon category when they're not strong. So the body just keeps throwing more and more tissue at it, and the ligament or the tendon gets thicker and thicker and thicker, because what the body's trying to do is to prevent failure of the ligament. And it can't create new ligament tissue very easily, so it just throws bad ligament tissue at the problem, and the ligament gets bigger and bigger and bigger, and that starts crowding out the nerves.
Laritha asks a great question. As patients want to know, what qualifications or training should we look for when selecting a doctor to do these kinds of procedures in the spine, like spinal stenosis or degenerative disc diseases?
Yeah, I think the first thing you want to do is to make sure that you have an interventionally trained physician. So what does that mean? That's someone who, as an example, you can separate the wheat from the chaff pretty easily by asking if the provider is going to do it under fluoroscopy or X-ray guidance. Having access to a fluoroscope costs 120 grand. The room, probably another 60,000. So you're talking about a $200,000 commitment to even use that equipment, and that equipment is really required for many of these procedures. So you've got that as the first screen. And then the second screen is making sure the doctor actually is trained to do procedures like epidurals, facet injections, and inject discs. And that one can be a little harder because we have clinics out there that do prolotherapy that will use the x-ray stuff, but they don't have any idea how to inject those structures. They just kind of use it to place it in this general vicinity. So you've got to make sure the doctor has training to inject those structures. And if what you're told is, well, the doctor can inject some facet joints, but he doesn't inject discs, then you're in the wrong spot. And then finally, you have to have a doctor that understands how to do this specific work with orthobiologics, stem cells and platelets. So the only type of stem cell procedure you can use right now is bone marrow concentrate and then PRP. So if what you're hearing is the doctor passes those first two tests and he does bone marrow concentrate and PRP, you're probably good. If you're hearing stuff like umbilical cord, quote, stem cells, which don't exist as a commercial product, or exosomes, then you're probably with someone who doesn't know what they don't know, so you probably want to run. So those are the three tests I would use when I look at these websites, trying to see who I'm dealing with. And obviously it's pretty easy for me to determine, but that's an easy way to look at it.
So Jeffrey asks, could this procedure benefit a patient with osteophytes in their central canal compressing the cord in addition to the ligamentum flavum hypertrophy?
Yeah, that's most of our patients. So we see patients, again, all we're trying to get here is another millimeter or two of room in there when they're standing up, and that's enough. So they can keep their bone spurs and those don't change. But by getting that ligamentum flavum to not buckle as much into the canal and to tighten down and to de-thicken, if you will, meaning to debulk, you're giving them that amount of room. So they can have all the osteophytes that they want in there as long as that ligamentum flavum on the backside isn't pushing the nerves against those osteophytes.
Stacy, the Florida office in Miami should open next month. So there's that answer. But a couple more questions regarding the spine. Henry wants to avoid a fusion. He had one and unfortunately is worse now than before. But someone had a fusion also and still has pain. Can we do anything with that? So similar questions.
Yeah, we can. So that's called adjacent segment disease, or ASD. What ASD is, if we fuse one part of the spine, regrettably, the energy goes above and below it. So you start to get breakdown above and below the fusion. And that's called ASD, or adjacent segment disease. Now, there's good news and bad news. The good news is we can generally help those patients by treating above and below the fusion. The bad news is that those are generally not cures. Those are more management tools because I can't get rid of the fact that certain levels are fused. So those patients, once we get them to a steady state, may come back every couple of years and get an update treatment, but it's far better than fusing the levels above and below, which then resets the problem and starts the clock ticking on the next levels that you haven't fused. So I would say, be very careful. Obviously, the first thing surgeons want to do when they hear this is they want to fuse more levels. Obviously, that's the opposite of what you should do because now you've got even more force on those levels above and below once you fuse more levels.
Yeah, kicking the can down the road for sure. Let's see here. What is normal desiccation of discs?
Yeah, so what that means, if you read that on an MRI report, is that it means that the disc is losing water. And when the disc loses water, it gets desiccated, meaning lack of water, and it looks darker on a certain MRI sequence called a T2. So that's a common thing. So it's a common thing for all of us. And what it means is that the cells inside the disc that produce water-hogging molecules, which are called GAGs, glycosaminous glycans, are just not doing their job in producing those chemicals. So the disc loses its ability to hold on to water. Realize that discs act as little sponges and they feed themselves through what we call imbibition. They imbibe. If you know that word imbibe, it means to drink. So the discs drink and they drink through compression. So if you're walking a lot, your disc is compressing and every time it compresses and releases, it's like a sponge. It picks up a little more water. Compresses and releases, it picks up a little more water. So Part of that happens because we don't walk as much as we should, or the disc gets injured and the cells start to die off. But that's also a normal thing for a lot of people with just getting older.
Let me see here. Jason, tell me more about your condition. And did you see a Regenex provider? And we can answer that better. Jean Paul asks, do you recommend to do disc seal first or after stem cells, or do you just don't recommend doing it?
Yeah, I'm not a big disc seal fan. Number one is, in order to get the stuff in there, you've got to create a huge hole in the disc, meaning the fibrin glue that's injected doesn't go through the types of smaller needles that we commonly use, meaning that our goal in injecting a disc is to inject it with as small a needle as possible. If you've got to use a 17 gauge needle, which is what's commonly used to get into the disc, that's a harpoon. So you're doing a lot of damage just to get that stuff into a disc. And then you've got the issue of does it work? We don't really know if it works at this point. There was one randomized controlled trial for an FDA approval that failed. And nothing else has been published since then to show that this is an effective treatment. Just so everyone knows, the concept here is that if you've got a leaky disc, the symptoms can be caused by the leaky disc, so you need to inject this fibrin sealant around the outer part of the disc. So at this point, I'm not a big disc seal fan. We don't use any disc seal at all. We don't attempt to do that. If we want to try to get the annular tears to heal, we'll inject those directly with bone marrow concentrate, again, with a very small needle, a tiny fraction of the size of the harpoon that you need to use to put disc seal in.
So good about discs. Let's keep going on that. 3 weeks ago, Johnny had an intradiscal bone marrow stem cell along with platelet lysate on his lower back at a Regenex clinic. Had a discectomy about 2 years ago and recently was bulging again. How long until I see results?
Yeah, it depends on what the goal is here. If the goal is to get rid of the bulge, that may or may not happen with a bone marrow concentrate injection. That generally is more the type of culture expanded cells that we use down in Grand Cayman. If the goal here is to try to stabilize that level, then that could be a good use for bone marrow concentrate, meaning the level is degeneratively unstable. So I would need to know more about what the goal was. But generally, if you're talking about disc pain, then if the disc itself was causing the pain, then generally it takes a good 6 to 8 weeks for those patients to turn the corner and start feeling better.
Here's a good question, and I don't even know what it is. When will pentosan polysulfate be approved for use in arthritis?
Yeah, that's a good question. It's used in horses here. It's used in Europe. There's some interesting information on it, but I have no idea. It's become very hard and prohibitively expensive to get that kind of stuff that's pretty generic approved here in the U.S. for use. So my guess would be never.
What is that?
It's a type of glycosaminous glycan or GAG.
Okay.
And it's been used in, like I said, vets use it here, but it's easier to get things approved by the vet version of FDA, or at least it has been traditionally.
Jason asked earlier about stem cell procedure. He had a T8 spinal cord injury. Doctor told me get feeling back and more mobility. I didn't get any of those. It was from Dr. Sessions, who doesn't sound like anyone in our network.
Yeah, so if you had a stem cell procedure for a spinal cord injury, is that what I'm hearing?
Yeah.
Yeah, I think listen, the kind of skill that you would have to do that kind of procedure right would require x-ray guidance, a highly skilled provider who could place the cells intrathecal in that area to make sure that they got to the exact right spot. And for most patients who would be further down the road, that would only work in the acute setting. For most patients who would be further down the road, you'd have to have neurosurgery where you're debriding the scar and placing those cells directly into that scar, or some sort of injection into that scar in the spinal cord. And then and only then you'd have to probably use a full-on culture expanded cell line. So my guess is that's not what you had done. And short of that, I wouldn't, well, we don't offer those treatments at all because we only treat orthopedic problems. But short of that, I wouldn't expect any results.
Sarah asks, is it possible to do something with a damaged and partially torn transverse ligament? Will it heal with stem cells or PICL?
Yeah, I mean, that's what we do with the PICL procedure. So the goal there is to target the transverse ligament, get it to heal and tighten down. So we routinely do that with the PICL procedure, including showing in other areas where it's easier to measure things like C1, C2 overhang, where that goes down over time as we tighten those ligaments.
So you talked to Johnny about his intradiscal and PL injection. It was L5S1 disc pushing on a nerve. He was asking again when he might see some results.
Yeah, so if again, it depends on what kind of disc we're talking about. If it's a disc herniation, then you should see results usually in the first couple of weeks, and might require several procedures to get you where you want to go. But that's an epidural injection around the nerves that play the lysate. If what you're talking about is a disc bulge, which is different now, that's where the stuff hasn't pushed out of the disc like a herniation, but there's just a bulge in the outer wall, and you're trying to heal that. That's kind of 6 to 8 weeks out, kind of in that time frame.
Sabina asked, do you inject specific cervical ligaments in caimans like the ventral dural, nuchal, and anterior and posterior longeal ligaments if needed, or do you do that only in Colorado as part of the PICL procedure? Also, do you recommend stand-up motion MRI or DMX to diagnose these ligament injuries?
Yeah, so when it comes to Cayman, we inject facet joints and all the posterior injections down there. We don't do any anterior injections down there, so the PICL procedure is not done down there. When it comes to, what was the second part of the question again?
MRI or DMX.
Oh, yeah. MRI or DMX. We generally prefer DMX. Simply because it gives us more information than a movement-based MRI. Now, having said that, there are times, maybe half the time, I can look at a movement-based MRI and get enough information to say this person's a good candidate for a PICL procedure. But then there's the other half of the time where it doesn't have enough information and we need to get the DMX anyway. So if you had to pick between those two, the DMX would be more important for what we're looking for. Obviously, the MRI has other advantages.
Marianne asks, are cysts in bone dead? If so, any way to resolve cysts in acetabulin with senolytics, or are stem cells in Cayman the only option?
Yeah, I mean, senolytics are not going to work for that at all. I mean, you have to realize what a bone cyst is. A bone cyst, so realize that bone has trabecular structure. So it's got these microstruts, and these microstruts are all over the place. And that's what keeps bone structure sound. Well, realize that a bone cyst is an area that has none of that those microstructural struts called trabecula, and it's an area that gets walled off. Now, the body is walling it off. It creates a thick shell around the area because it's trying to keep the bone from failing. The cells that maintain that trabecular structure have died off, so it's trying to make sure the bone just doesn't collapse. And the only way it can really do that, it can't recreate the trabecular structure on its own, so it just creates a dense shell of void in the middle. Now, have we gotten bone cysts to resolve? We have. If you poke through and through them a couple times and inject even bone marrow concentrate, like a same-day procedure here, plus demineralized bone, you can sometimes get them to resolve. So that's a good thing. And sometimes it's not necessary to get them to resolve, meaning that the bone's doing fine there. So it just depends on where the bone cyst is, how big it is, and what the goals are. But these are areas of dead bone.
And why did the cells die in the cyst? She's asking as well.
Because we all, as we age or as we get sick, get into this world of repair versus wear and tear. So when wear and tear exceeds repair, things die. When repair exceeds the wear and tear, things don't die. That's in fact most of what we're doing with these autologous stem cell or platelet procedures. We're trying to ramp up repair to make it bigger than wear and tear. To the extent that wear and tear exceeds your ability to repair, cells die.
And Vedette had PRP and SCP for patellar tendinosis, and still has a little pain around the tibial tuberosity. It's been about 8 months. Is that still?
Probably needs to get hit a second time. And then you have to ask yourself biomechanically what's happening there. So a good thing to understand there is that you would have to really start doing a lot of glute work and hamstrings work in order to offload your quadriceps mechanism, meaning that front patellar tendon. So if you're not doing glute work and hamstring work like crazy every day right now, you're probably not doing it right, meaning that you've got to take the weight off of that area, and the reason why it's failing is because your glutes and hamstrings went south.
2 questions from Gabby. I'm getting to it. How do we assess a functional versus an anatomical short leg, and can you inject the vertebral end plate?
Yeah, those are 2 different questions there.
Exactly.
So, so a functional short leg would be if there's, let's say, a little curve in the spine and it pulls the pelvis up on that side. It can be corrected just by pulling the leg down. A structural short leg would be that the leg is physically not as long, and that's usually an X-ray determination where you can measure those bones and see if it's actually structural or functional. And then when it comes to injecting the vertebral end plate, it's possible to inject, but my concern there would be hurting the end plate. Realize it's kind of like a fibrocartilage bony thing, and it's a lot like a plate, meaning that a china plate, if you hit it the wrong way, can break. The end plate is very similar to that, so I think you'd be far safer to treat inside the disc and try to improve the health of the cells inside the disc that communicate through the end plate with the vertebral body, or go on the other side through the pedicle into the vertebral body, or both, to try to treat the end plate rather than injecting directly into it, because it can be like a china plate and break.
So you answered most of Vendette's question about the patellar tendinosis. Issue is he still has inflammation from the injection after all this time. Not so much pain and the swelling went away, but some inflammation. Or the edema went away.
Yeah, again, it's probably going to require a second treatment, but I would need to know more. And if you don't have glutes of steel by now, this is not, you're not doing the rehab portion. I mean, I'm talking about, we have a glute program that I put on the website. That would be a good one to look up. Because again, if you don't have glutes of steel, meaning if your glutes aren't kicking in every time you look over your shoulder, then you're not doing the rehab program that needs to go with this.
Catherine asks, how do you determine which type of injections for injections to L5 for lumbar radiculopathy, lumbar degenerative disc disease, platelet lysate, or stem cells?
Yeah, so what we have found in spine work is one of the ways to tell if you're dealing with a clinic that really doesn't know which end is up is if all they're offering you is, quote, stem cells. Now there's 2 categories of those clinics. One clinic is offering umbilical cord stem cells and amniotic stem cells. That's all bullshit. There is no such thing. Meaning we don't have any commercial product that contains any live amniotic or umbilical cord stem cells. So if you hear that, just run. Then you've got the next level of folks using something like bone marrow concentrate, which contains stem cells. But the big problem there is if all they're offering you is that in the spine, then again, run. Because about 70% of the time to 80% of the time, we're not using stem cells in the spine at all, and we're getting great results. We're using platelet-based procedures like PRP, platelet poor plasma, platelet lysate. And for degenerative disc disease, that's kind of a sweet spot for that treatment, meaning that you can tighten down ligaments, treat irritated joints, treat irritated nerves, and those patients do very well with a procedure that costs a third as much as a stem cell procedure. So again, I always tell patients, my job is to find the least invasive, least expensive thing that's the most likely to work. And 70 to 80% of the time in the spine, that's platelets. So if all you're hearing is the only thing we do is stem cells in the spine, you got to rank amateur, and it's time to run.
Right, exactly. I was going to say, that's you've got all this experience utilizing these, so you know what works because you've got a big toolbox, and it's not just a one-trick pony.
Yeah, I mean, again, platelets work very well in the spine, but they've got to be used in specific ways. They've got to be injected in specific areas. They've got to be injected in specific concentrations and specific types, like the difference between PRP and platelet lysate, that kind of stuff. But again, platelets work really well in the spine.
Stacy asks, why does sitting in the car always make cervical spine instability pain worse than other sitting?
Yeah, it's because of instability and muscle problems. So realize that if you're in a car or in a boat, and especially if you're the passenger, you can't tell where the next hit is coming from. You don't know if you're going to be jostled to the left, to the right, forward, backwards. So you can't pre-plan that motion. As an example, if I go to reach for this camera right now, 100 milliseconds before my arm moves, so 1/10 of a second, my spine muscles contracted to keep my spine from collapsing. So that's a pre-contraction. You can't do that if you're riding in a car. Now, if you're the driver and you see a pothole, you could do that. But many patients with craniocervical instability, the muscles are fried as well. So not only are the ligaments not working, but the muscles don't work either. So even if you saw the pothole, you couldn't contract your muscles quickly enough in order to protect the area. And you'd have to contract them well before you hit the pothole, not after.
All right. Cristoforo, you must be traveling. So after stem cells and PRP here in Broomfield, how much time is good to rest before leaving?
Yeah, I just wrote this up today for our patients that travel. Basically, I'd give it a good 2 or 3 days. Now, if you're traveling from out of the country, then I'd probably even give it a 1 or 2 days beyond that. So if you're traveling here just within the U.S., I'd give it at least 48 hours before heading home. So what that means is you want the next day nothing, and then if you fly out the following day after that, it's going to be towards maybe in the afternoon so that you could be seen in the morning if you needed to be seen in that morning. But if you're traveling internationally, give it another 1 or 2 days beyond that because you want to make sure that everything is just fine before we send you back home on that international flight. And if we need to see you back in the clinic to check you, that's easy to do.
How does anemia affect the stem cell treatment?
Yeah, anemia can be a problem because when we're using an autologous stem cell treatment, we're using usually platelets. Now, many times we can get the needed platelets out of the bone marrow aspirate, so we don't have to do a separate blood draw. But anemia just reduces the amount of bone marrow or blood that we can take. So if you're very anemic, that's going to reduce what you have in the tank, so to speak. It's a little bit like driving, right? You got a full tank, you can go further. You only have a quarter tank, you're not going to go very far. Same thing, if you only have a quarter tank full of blood, which is what anemia would be, then we can't take as much out of the tank because you need some in there to keep driving.
And I know we have an app, right, that you use to determine...
We do. So Regenexx has developed an app for its providers that we developed here in Broomfield that uses the American Association of Blood Banks, AABB guidelines. And they can just plug in what the doctor wants with our products, and that tells them exactly how much they need versus how much the patient has. So you put in the patient's hemoglobin plus their age, sex, and weight, and it determines how much is safe to take. So if there's a mismatch there, the provider can be alerted, hey, you're asking for more blood than we should take from this patient.
Let's see, someone really enjoyed, and I liked seeing this too, the exercise blog you did on your website for post-PICL. How soon after a procedure can people start doing those?
Yeah, it's a very good question and a really critical question to understand. Most CCI patients would really need to be a couple months after their first or second procedure before they consider starting those. Now, you could start the 0.5 level program, which is where you just look at the targets with your eyes. That's going to contract these muscles a little bit. But you're going to need to be, most people probably after the second procedure before you dive in there, some people after the first. But that's a couple months after the first or a couple months after the second. And it's not a bad thing to check it out, to get all the equipment and just see where you are. If you do 2 reps of the simplest exercise and that flares you up, you're not at the place where you can start those. So it's very much listen to your body as well, but realize that the program is structured to go from the absolute easiest all the way up to the hardest. And I'd really, really love feedback on it from as many patients as possible.
Along the same lines, Johnny, who you talked to earlier with the L5 disc bulge, wants to know, when is it okay to start doing PT or doing some exercise?
Yeah, so that's going to depend on your symptoms. So generally those procedures, our activity is tolerated. You want to be not doing much for the first couple weeks, but after that you want to integrate activities back in as quickly as you can without pushing it over the edge. So what I mean by that is if the pain in your back is 2 out of 10 or so, and you're doing some activities, then that's fine. If the pain jumps up to a 5 or 6 out of 10, then you're not ready yet to do that activity.
And Stephanie asked, do EDS patients with CCI have as good a results as those without?
Yeah, as I've told patients before, about 20% of our patients with CCI or EDS spectrum, I don't see them doing any less well than any of the other patients we have. Now, the biggest difference with many of those patients is they frequently have lots of different areas that are problems, not just their craniocervical junction. So they might have knees that are problems, or shoulders that are problems, or a back or an SI joint that goes out. So sometimes we're treating a few different things in those patients, but I don't see them doing any less well than your average patient. Other than they've got a lot more problems walking through the door than someone who was in a football accident and fell on their head.
So I think it's a good one to answer as well. Richard asked a while back about hip osteoarthritis, and I know we have some specific answers around hip OA. Now, I don't have a specific question about it, but I'm sure you can answer that, hip OA.
Yeah, and hip OA is interesting because unlike knee osteoarthritis, a patient who has severe knee arthritis can do very well with a same-day stem cell procedure or a bone marrow concentrate injection. A patient who has severe hip osteoarthritis isn't going to do well with that kind of procedure and may not even do well with a cultured procedure depending on what's going on. So realize that severe hip osteoarthritis almost always needs a hip replacement in our book. And if you really wanted to try to avoid a hip replacement, we're happy to try to help you, but we're going to dampen down your expectations quite a bit.
Listen, great questions. I want to make sure that you know about our resources. We've got numerous books Dr. Centeno's written: shoulder, spine, knee, our General Orthopedics 2.0, an Amazon bestseller. These are great resources. We've got webinars on spine, knee, and just general stem cell questions if we're going a little too quick or maybe didn't get to your question today. But also the best place to get an answer is to find a local Regenexx provider near you and schedule an appointment. Go in with an MRI, or they can order an MRI, and sit with them for about an hour and really ask all your questions, let them do a good thorough examination, and find out where they can help you or how they can help you.
Yeah, we also have a Facebook group, the Ask the Experts stem cell Facebook group, and that's a good place to get questions answered as well. We have a lot of patients that go on there. We try to keep answering questions to physicians only. So it's a unique Facebook group. You really don't see any other Facebook groups out there where it's staffed full-time by physicians who are tasked with answering these questions, and only physicians who have experience in this area. So it's kind of a unique Facebook group. It's also a little bit more controlled than many of the Facebook groups, because many of the Facebook groups I've seen out there are kind of the true Wild West, meaning you've got paid clinic promoters on there, you got product promoters on there. We don't allow any of those folks in this Facebook group. This is only patients and doctors are allowed to walk through the door.
I didn't see whose question came up about where you can do spine procedures in New York City, but if you go to the Regenexx.com website, find a physician. You can find who's in New York City. I know Dr. Rob Cranberg is there, and we've got some other providers.
And Rob was actually, I believe, our first provider on the network. I think he joined the network in like 2012. So Rob's been doing this stuff a long time.
Simran, can anything be done about a damaged anterior longitudinal ligament at the C2-3 level?
Yes. Direct injection through a disc access approach would be one way to get there, or through the PICL approach we can get there. So there's two ways to get there at the anterior longitudinal ligament. So yes, at that level.
Vedat asks about a mild disc bulge and a broad-based disc bulge, disc protrusion. What type of PRP would be used? And since it's not an all-out herniation, is it likely that it could heal over time with proper exercise?
Yeah, I mean, starting backwards first, exercise and strengthening your core is absolutely key and critical. So that's a big component of everything we do. Then you get into orthobiologics that you could use. If you're trying to get rid of the disc protrusion, the only reliable way I've seen to do that is the type of cell therapy we use in Rankamen. When it comes to PRP or bone marrow concentrate, that's less likely to get rid of a disc protrusion. But again, sometimes it's not necessary to get rid of the protrusion at all. It's necessary to stabilize the area, focusing with platelet-based treatments in the ligaments and the muscles, in irritated joints, around irritated nerves, and those patients do very nicely. But exercise is always a really big component of this and getting your core strong. You know, I got to tell you, I've been working on my glutes for the last year, and it has made such a huge difference in my back. It is absolutely, I would highly recommend it, a structured glute strengthening program. You know, we all get these flat butts as we age, and you can see it just looking at old people walking around. The skinnier they are, the more flat butt that you see. But it's absolutely critical to protect your back. So it's not hard to do, it's not complex to do, but it's absolutely something that will change your life if you've got chronic back pain.
What are you doing? I'm just curious. A couple of them.
You know, I started with simple bridges and then fire hydrant type things. Then I created what I call the Booty Blaster, which is a big, thick rubber band wrapped around the end of a squat cage where you get in it and you're actually doing resistance in your bridges. And, you know, it has made, I mean, such a tremendous difference. You know, I've had some low-level chronic back pain. Nothing that requires a lot of treatment, but just low-level stuff, and it's made a tremendous difference in what I can do and how often my back will get flared up by doing stupid things.
That's great. All right, well, this has been a great conversation about spine. As you can tell, it's just not as simple as maybe as you can read online about, or providers making claims that they can treat all kinds of things or giving you numbers of discs they injected.
Yeah, be really, really careful out there. I mean, I would say that right now, out of 20 places that are advertising that they're doing stem cell therapy in the spine, probably only one of those sites is actually trying to do it seriously and do it well. 19 are either totally fraudulent, meaning that they're not doing the procedures that they claim they can do, or that they're making patients believe that they can do, or they're not even using live stem cells. So be very, very careful. It's about a 1 in 20 proposition right now to find that needle in the haystack clinic that's really trying to do this well. So you can do that on Regenexx.com. There's also, outside of Regenexx, the Interventional Orthopedics Foundation, which is a good place to go and look up members of that group because they're taking it seriously. So those providers are out there. You just have to do your homework and be very careful. It is so easy to get taken in this area by a clinic that, if you read the website, you think they can do this, but if I were to walk in there, I could show you that they're only really doing this. So you're paying for this, but what you're getting, in fact, is that.
Yeah. All right, so we're going to be, I'll be out of town next week, so we're taking next week off.
Yep.
But we'll be back in 2 weeks at our regular 4:30 Mountain Time. Thanks for tuning in.
Thanks, guys.